Good morning, everybody. My name is Nikki Keefe from the University of North Carolina. I'm interviewing on the behalf of the VLU Voices newsletter. Today, I have with me Dr. Kush Desai. He's an associate professor of radiology, medicine, and vascular surgery at Northwestern Medicine, as well as Dr. Minhaj Khaja, who's a clinical professor of radiology and cardiac surgery at the University of Michigan. So welcome, both of you guys, and thank you for joining me.
Good to be here.
Yeah, good to be here. Thanks for having us.
Both of them are experts on venous disease. And so we're going to be talking about a lot about some of the more out there treatments for DVTs. That's not the standard PE DVT that we deal with. The disclaimer I'd like to make is that the devices we talk about today, we don't necessarily endorse one over the other. And we're going to be talking about a lot of things that are not data driven, just because there's not great data on this. So a lot of it is just clinical gestalt and opinion based. So let's start off with talking about the pediatric patient with DVTs. Kush, what is your go-to for treating pediatric DVT?
You know, those are some of the most difficult patients to to really make the decision. And fortunately, we have a standalone peds hospital, as I'm sure both of you do too, and we have dedicated peds interventionalists. But I do get called into those cases, and I think the first question always is what age are they? What's their growth potential? Should we treat them, right? Because the sort of the natural history of PTS and peds is actually very different, anecdotally at least, from adults. And so if they're, older teenagers, that kind of thing, I know my peds colleagues would probably hate this. We can consider them young adults and maybe be a little bit more aggressive as we would be for an adult. But for the younger kids, we probably hold off on intervention most of the time. But if it is a closer to an adult size child, what we typically employ the same techniques and tools and approaches that we do in adults, with the caveat primarily being around whether we should stent or not. If it is, say, for example, a left iliac vein compression, and that's gone both ways. We've been too cautious and they've rethrombosed, and you're bringing them back, and probably should have done it the first time. And maybe other times we've been too aggressive. And so it's a moving target.
So Minhaj, talk to me about how you might stent a pediatric patient. Say, they're still growing, they're early teens, like 13, 14, they're still going to get bigger. How would you size that?
Yeah, that's a great question, a tough question. I think, as Kush mentioned, we frequently like to kind of assess their growth potential, kind of look at if they're if it's a young male, how big is his dad? Is he close to that in age and size? I think that I sort of go by the standard norms that I would use again on an adult to a certain degree, because of that potential. We don't want to again undersize that stent. Very important. So that if they grow larger, that you're going to end up having a stent that's potentially going to migrate over time, although it'd probably endothelialize. I do think I use IVUS, very important in all of these patients. And I think for everything we're going to talk about, I think IVUS is really important. So I definitely would like to size based off of a reference vessel, keeping in mind what the contralateral vessel may be, and then again, their size. So I don't have a definitive answer. Like I can't say a size, but I would say when you are considering stenting, especially even more so maybe in these patients, is to anchor that stent better, even because if you go a little bit on the smaller side at that point, maybe like a 14 mm stent, if you're going smaller, that you have good anchoring in that external iliac vein if it's not affected.
Good point. Last question on peds is, are you choosing a specifically atraumatic type of device like an angiojet over something that might be a little bit more aggressive on the veins?
For me, I try to avoid the more aggressive endothelial wall damage on anyone, to be honest. But I think even for that pediatric patient, some of those devices, for example, are larger in size, with their basket, for example. And I think that is going to be even more worrisome in a child who's got smaller veins, and really a longer term for damage to occur. So I would definitely size down and maybe pick a different type of device.
Yeah, the size constraint really is also going to be the access site, right? 16 French is awfully big, even in an adult, and we do it. and we do okay with it. I'd be a little bit more worried in a kid.
Okay, let's change directions and talk about the portal system. So for portal SMV thrombus, how might you be treating that, Kush?
I call my partner Bart Thornburg. No, no, we have we're fortunate here at Northwestern to have experts in different areas, and we have some really world-class experts in portal hypertension here. But you know, the decision on whether you perform thrombectomy in acute portal vein thrombosis, for example, is nuanced. And I think most of us probably still favor anticoagulation unless you're seeing a tilt towards progressive pain, lactate elevation, a threatened patient from a thrombosis perspective. We have seen patients just get better on anticoagulation alone. So again, and I think that's the theme of this whole session, the data's muddy. How do you treat it? And you let labs and symptoms be your guide, I think, frankly, far more than imaging for performing acute portal vein thrombectomy.
Minhaj, if you do move forward with thrombectomy, are you in favor of doing a direct percutaneous stick to the portal system or a TIPS approach?
Yeah, I think I agree with the comments that Kush mentioned also about having partners who do more of this. But I do, in my experience, I generally like to go a TIPS approach because if you're already placing that TIPS, I like to clear the clot and then place the TIPS in, or at least get the access across and then place the TIPS and open it up. I personally like using obviously smaller devices for this. And when we go into the SMV or into the kind of the portal vein past the confluence, I try to prefer using angiojet a little bit to get some flow going. If I'm going to use a thrombectomy device, I use aspiration thrombectomy, smaller bore. I do think that there is benefit when sometimes you do need to go to transhepatic percutaneous access to keeping it small. And so in general, I try to get a 7 French type of sheath. And again, I think an angiojet thrombectomy catheter works really well for that. And then you either coil or glue on your way out.
I'll just add one bit, which is that figuring out the cause of acute portal vein thrombosis is that's absolutely key. And I submit it's harder than it is in DVT most of the time, because in DVT, if we don't know, we just say it's unprovoked. But I don't think that you really can't do that in portal vein thrombus. It's on you to find the cause. And is it something like as simple as recent surgery, diverticulitis, recent bowel surgery, diverticulitis, appendicitis, or is it something more sinister like JAK2 kinase mutation, for example, that has significant implications for how the patients manage for the rest of their lives. So finding the cause, I think, is really important when you have an acute PVT.
So, Kush, if you were to go a TIPS approach and opt to leave a TIPS in someone that does not have background portal hypertension, would you place a TIPS that could eventually close down, or would you place a standard Viator stent?
Yeah, I think I'd still place a standard Viator stent. The idea being that, if we need to go back in and clean it out, because you can't clean out all the peripheral portal vein branches. So just thinking about simple physics, you have a large parallel resistor that's probably still filled with clot. You need to give it outflow to maintain the main trunk, the series resistor that's, the splenic vein, the main portal vein, extrahepatic, infrahepatic portal vein. And then you can include the TIPS, or if they don't have background portal hypertension, it'll include on its own, right? Because that's a much higher resistance than an open liver. So I personally leave that Viator in so that we can keep it open, and we have a lot of experience with that device.
Great. Shifting gears again, let's talk about pregnant patients, because it's not uncommon that pregnant patients will get lower extremity DVTs. Minhaj, how do you treat that if the pregnant patient's pretty symptomatic?
Yeah, that's a really common and really controversial topic. And I think the first step is to decide where they are in the pregnancy. Of course, if it's early on or late on, for multiple reasons, whether it's the effect of radiation on the fetus. Also, are you in this for the long haul? If it's early in the pregnancy, can you get away with anticoagulation? Obviously, enoxaparin is the drug of choice there. But if the patient is severely symptomatic, if their Villalta score is in the high range, and they're really miserable, I try to approach it as whether we're going to just perform thrombectomy, thrombolysis type of procedure, if you're going to consider stenting, which again, that's a controversial topic and one I try to avoid placing stents in. And then really, again, it is what is the long-term C induce? It's hard to evaluate the IVUS, I think, on any of these patients. Is it because of the fetus? Is it because of underlying May Thurner? And try to really weigh the risks and the benefits of whether you're going to do something at all. As Kush probably has experienced, there are patients who you can let it ride out. We do know that if you have common iliac vein involvement in many of these patients, that they have a higher risk for PTS. That's been shown out in multiple studies. But sometimes it's okay. It's worth the risk, I think. And really having a thorough conversation with the patient and their family, as well as the medical teams, is important.
So, Kush, if you have a pregnant patient who is leaning towards phlegmasia and you are forced to treat her, what would you do?
So fortunately in my career, when that has occurred, and it's not maybe phlegmasia, but really severe symptoms, you're getting close to the end of the third trimester. You certainly have fetal viability. If it happens in the second trimester, that's a really difficult decision. I don't know how much you can, I mean, you can do the case, and if it's about saving a limb, if it's true phlegmasia, which again, I think is over-invoked and really not there as often as people say it is, right? I've seen phlegmasia exactly once in my career, like real phlegmasia. But if it's a really severe DVT and, they're, 28, 29 weeks, I try and ride it out, get them to fetal maturity, obviously MFM's on board. And then if it's really significant, we've had these patients deliver a little bit early. You have fetal viability, and then we treat them right afterwards. I will say that anticoagulation in the postpartum period, the mistake I made early in my career was relying on unfractionated heparin. It's a critical mistake. Unfractionated heparin in this country is just awful. Batch to batch variability, you don't know what you're going to get. I put them on Lovenox. I supplement with heparin on the table. I over anticoagulate these patients because I've then had the reverse of then I'm chasing issues for years with, stent buildup, thrombosis, this, that, the other. And it's all because we relied too heavily on unfractionated heparin. I will say that if it's a typical severe but not phlegmatic iliofemoral DVT in the late first or second trimester, I really don't treat. I just anticoagulate and I treat it as a PTS patient later on.
If
Okay.
I may
let's
add one, may add one thing, I do recall a case that maybe you and I have done in the past, Nikki, on a pregnant woman who we decided to proceed with. And I would just add that you can do a lot of these cases with just intravascular ultrasound or predominantly. Obviously, you can shield, but you're working in that area. And so you can do IVUS runs pre and post, and then put in whatever device you're going to use. Again, I really like AngioJet with a little bit of TPA. There is data in both directions about what TPA and hurting the fetus, but it doesn't cross the placental barrier. But we don't like to leave patients on it as much because there is an increased risk of placental abruption. So I run IVUS through, demarcate our areas of thrombus, maybe put AngioJet or another aspiration type of thrombectomy catheter in, and then IVUS again, and maybe do one venogram and feel decent about it.
Yeah, the nice part about IVUS, it's got the markers the entire way, so you can measure externally how far you've gone without fluoro. But talking about, more of the chronic patients, how do you guys treat that chronic in-stent stenosis? So why don't you start, Kush? What is your go-to?
Yeah, I think we're starting to see innovation in this area with not only crossing devices, which right now we're cobbling stuff together, but there's purpose-built devices on the way. And you all do these cases. Crossing these things is, it's a labor of love. It's certainly not reimbursed. But you do it because it's the right thing to do. And then what to do about that material. We all know it's not clot, right? People might say it's clot. It's not clot. It's type 3, type 1 collagen. It's concrete. There are some devices with the intent of removing that material and debulking it, which I think is a welcome move in that direction. but we're not there yet. I'd like to see a solution that can really get, let's say it's a 14 millimeter stent that's occluded. I'd like to get it to 12 reliably with the balloon, and it's going to stay like that. So that we don't have to come back, one, and two, or come back as often, and two, we're not relining with the stent. I have moved away from relining, if at all possible. There are sometimes you have to. If you have to extend it because of missed inflow lesion, missed outflow, bridge lesion, whatever, fine. But if you're, early in my career, when I used to reline stents, I've now found that you end up sort of behind the 8 ball.
Yeah,
Minhaj?
I think Kush hit it right on the head there. There's two problems there. Well, three. Number one, finding out why it went down, first of all. Before you really get even into, well, what am I going to do, is why did this happen? And sometimes you can't figure that out until you're in the intervention itself. I think that's important. Number two is getting across. And as Kush mentioned, getting across, there's lots of different variations of tools, needles, wires, radio frequency wires, balloon needles, using arterial type of devices, figuring out what you want to do. But once you get across is also debulking and or just getting it open. And I agree with Kush. I do a lot of relining of stents, but I do reline more cautiously than I did earlier on in my career as well. Because we do know, and we both, Kush and I, research on this, is the different types of material. It's all some form of hard collagen, but sometimes it can be mushy a little bit in the middle of the stent. It can be like a rubber cement, or it can be like concrete. And getting that to break up and place a stent that's again, if you had a 14 millimeter stent, you want to get a 12 millimeter lumen, is hard. I will say some of the recent advances, so specific devices, would be the RevCore device or the VenaCore device. I've had some experience, probably done about 20 cases or so with RevCore. And I'd say in my experience, about half of them have made a difference. I can't pinpoint which patient. I do recall I've done some that have been occluded for 10 or 15 years and some that have been occluded for like a year. And I can't say which one it's going to work in well. But I've done IVUS pre and post without any ballooning and have gotten some luminal gain back. And so I find that to be helpful. I will say that I think Inari has also come out with that Protrieve sheath, which is like a filter built onto the sheath itself that you can work through. I think that has been useful. I think others have used it for complex filter retrievals, for thrombectomy, and so I find that to be useful. I've tried arterial atherectomy devices like Diamondback. I've used laser atherectomy, and many of I've used intravascular lithotripsy, just all off-label. And I've found not that much success in any of those. The thing that I've seen the most has been the RevCore device, and recently have used the Flash 2.0 by Penumbra in some of these cases, and surprisingly pulled what was some chronic appearing material within the stent out. But again, that's just been a couple of cases.
So you brought up some of the newer devices. We've got the standard AngioJets and Penumbra and Seminari, but there's a whole lot more that have hit the market recently. Kush, do you have any experience with some of the newer devices and any benefits that you've seen from them compared to the ones that have been around for a little bit longer?
I've used, I think, the only one of the newer ones that I've used is the Helo device, which is endovascular engineering's device. It's an aspiration catheter. It works well, right? And I suspect the answer to the question is they all work well. They're iterating and building on what's out there. The question now becomes, what are they going to move the procedure, the intervention, in a really positive direction to support the number of devices that we have available to us? I think that's the real question, and I don't know, right? So the first thing we need to do is ATTRACT showed in an RCT that pharmacomechanical therapy works in moderate to severe patients or worse with iliofemoral DVT. We now need that level of data for mechanical only devices, because you saw the whole push like, oh, TPA is dangerous, which I disagree with. TPA used judiciously is actually not dangerous. My publication record supports that, but I think it is nice to be able to use less TPA and maybe sometimes you don't need it, but if you don't need it, it's on us to actually prove that you can get the same quality intervention with the mechanical only device in an unbiased manner, right? So we need bias limited, bias controlled studies, and we can't just rely on industry trials for that.
Mhm. Minhaj, how about you? Any experience with some of the newer devices?
You know, I mentioned a couple of them. They're on the market. But you know, the RevCore and VenaCore and the Flash 2.0 are things that I think in both the acute and the chronic setting have been helpful. But I don't know what the long-term benefits of those, as Kush mentioned. I do think for the chronic in-stent lesions that there are other, again, more devices that are variations on the theme are helpful. I think what's important is knowing that each one of these devices has a slight change. I think that there's you know, some newer devices are taking technologies that have worked in other fields, maybe whether it's neuro or arterial, they're adding a little venous flare to it. And you have to be able to pick and choose what's right for that specific scenario. So whether you have acute clot, you have some chronic chronic collagen, a combination thereof, you want to use some TPA, you don't want to use it, you need to debulk. I think that there are multiple different tools out there. I've seen a different types of combination devices. There's a new catheter that's coming on the market that has a morcellator sort of on the tip with and thrombectomy or mechanical thrombectomy. So you're getting a combo of two different prior devices put together. You have multiple different combinations of now baskets that go through aspiration catheters. I can't recall all the names, but I think there's like 3 or 4 in the works. And so I think that there are potential benefits to many of these devices, but I think it's going to have to play out in the appropriate clinical situation.
So to close this out, I'd like to ask you guys one final question. If you could think of one device or functionality that's missing in your armamentarium that you need to improve the treatment for these DVT patients, whether it's acute or chronic, what are you looking for in future devices that come out? Kush?
I'm looking for something that's going to be able to reliably debulk stents. I mean, it can't be 50%. It has to be like 90+%. Maybe even deal with dystrophic calcification, because I see that too much, and really nothing works for that. And I've tried and something that's safer, lower profile. You know, I think if you're talking about a post-thrombotic patient and you already have compromised inflow and you're using big sheaths to get these devices in, and then you're putting in something 20+ French in the neck to catch it, it's just clunky. We got to get it's got to get cleaner. It's got to get more. It's got to get more efficient. So that, to me, I'm going to cheat and say a second thing.
Okay.
I want a stent with some sort of protective property, antithrombotic property baked in. So at least in some of these patients, we don't get there, right? We build in a margin of error because life happens. Patients forget their blood thinners here, there. You know, most of them are well-meaning, and if we select the right patient, but I mean, I forget stuff, and everybody does, and so we need to have something that's baked into the stent to protect these patients.
I think you bring up 2 very good points. Sometimes I wonder, are we hitting in-stent stenosis with the wrong thing? Why are we debulking when we could melt it with a chemical? What about like a collagenase? But then the second point is, you know, we've got stents that are not for venous disease that have drug coating. You know, maybe that's the next place to go. Minhaj, any opinions?
Yeah, I'm also going to give you 2. The first one I'm going to start out with is the same that Kush ended with, which is a stent with some sort of coating. But I want to propose maybe a drug coating that is more like paclitaxel or a sirolimus that can reduce the endothelialization and the inflammation. And so I think you know, as we all know, there's more and more discussion about the inflammatory component of venous disease. And I think that something that can help reduce that would be helpful in the long run for both the acute and the chronic patient. The second point I'm gonna say, and Kush will know my bias towards this, is those devices to help us cross safer, more if time efficiently, and actually help us get through easily. I think we all have our own build your own kit. Maybe you have a plan A, plan B, and a plan C, and then, you know, put them all together. But I think having some indicated type of devices that help us safely cross both native occlusions as well as in-stent occlusions, but they may be different devices. We have some now that we kind of build your own, but I think it'd be really great to have that and have a really safe tool.
Well, thank you both so much for this invaluable discussion. Your opinions are highly regarded, and I appreciate your time today.
Thanks for having us.
Yep, thanks for having